Hello and welcome. If you're an anesthesiologist, you know that the liver transplant operating room is one of the most challenging environments we can possibly work in. It's a physiological roller coaster. Today, we're going to do a deep dive into the one tool that has truly revolutionized our ability to manage these complex patients, Transesophageal Echocardiography, or TEE. We'll explore how it's gone from being just a helpful monitor to an absolutely essential guide for navigating this high-stakes surgery. All right, so here's our game plan for today. We're going to start with the fundamentals, outlining TEE's evolving role throughout the distinct phases of the surgery. Then we'll tackle the big, important questions around patient safety, especially when it comes to esophageal varices. From there, we'll get into the real nitty-gritty of using TEE for advanced diagnostics when your patient becomes unstable. We'll also cover how to manage those critical, life-threatening cardiac events. And to wrap it all up, we'll take a peek into the future and see what's next in the world of echo monitoring. Okay, let's jump right in. Section 1. TEE's role across the surgical phases. You know, we often hear liver transplantation described as a hemodynamic storm. And honestly, that's not an exaggeration, is it? We see these profound, rapid, and often unpredictable shifts in preload, afterload, and cardiac function. In that kind of chaos, our traditional monitors, well, they can sometimes leave us guessing. And this is precisely where TEE steps in. It's not giving you a calculated number, it's giving you a direct, real-time visual assessment of the heart. It lets us see exactly what's happening so we can navigate that storm with precision and confidence. The surgery itself really unfolds like a three-act play, and each act presents its own unique set of hemodynamic challenges. Act 1 is the Preanhepatic Phase. This is all the dissection and mobilization of the diseased liver. It sounds like prep work, but it's fraught with danger. The potential for massive hemorrhage is always there, not to mention the huge fluid shifts as liters of ascites are drained. Then we enter Act 2, the Anhepatic Phase. The clamps go on the inferior vena cava and the portal vein. Suddenly, cardiac preload just plummets. This is a massive stress test for the patient's entire cardiovascular system and a time of extreme vulnerability. And just when you think you're through the worst of it, you hit Act 3, the Neohepatic Phase. The new liver graft is reperfused, and bam, the heart is suddenly flooded with cold, acidic, hyperkalemic blood from the preserved organ. This is the moment we all dread, the onset of reperfusion syndrome. TEE is our constant companion through all three of these acts, but its role changes dramatically in each one. Let's break that down. So, how exactly does TEE's job change as the surgery progresses? Well, in that first preanhepatic phase, it's all about reconnaissance. We're establishing a solid baseline, confirming what we saw in the pre-op workup, but also actively hunting for any surprises. You know, things like a patent foraminal or PFO that could set the stage for a paradoxical embolism later on. It's also absolutely critical for assessing volume status in real time, especially when there's major bleeding. Then, in the anhepatic phase, when preload has tanked, TEE becomes our guide through the desert. It gives us an immediate picture of volume status and lets us spot dangerous complications like hypovolemia-induced left ventricular outflow tract obstruction before they spiral out of control. And finally, the neohepatic phase. This is where TEE becomes a true lifesaver. It is our single best tool for figuring out why the patient is crashing from reperfusion syndrome. Is it acute RV failure? Is it a massive thrombus flushed from the graft? TEE gives us the answer instantly. Okay, so we've established that TEE is an incredibly powerful tool, but we can't talk about its immense benefits without having a very serious and honest conversation about safety. Let's remember who we're dealing with. These patients with end-stage liver disease are among the sickest in the hospital. They are often profoundly coagulopathic, have severe thrombocytopenia, and of course the big one, they frequently have large esophageal varices. This reality demands that we rigorously balance the incredible diagnostic benefit of TEE against the potential for very real harm. And this brings us right to the elephant in the room, doesn't it? This is the question every single anesthesiologist asks. Is it really safe to advance a TEE probe down the esophagus of a patient with known varices? For many years, the presence of significant varices was considered a strong relative or, for some, even an absolute contraindication. It was a huge red flag. But that was then. What does the modern data actually tell us about the risk today? Let's look at the evidence. The number is 0.97%. Let that sink in. A major systematic review and meta-analysis looking at over 3,000 liver transplant patients who had intraoperative TEE found the pooled incidence of variceal bleeding to be just under 1%. Now, is that risk zero? Absolutely not. Any variceal bleed is a major life-threatening event, but you have to weigh that risk against the benefit. The incidence of severe, life-threatening hemodynamic collapse during this surgery is much higher than 1%. When you frame it that way, the data strongly suggests that the benefit of having TEE to guide you through those frequent crises far outweighs this low, though very real, risk. So, this table really helps us organize our thinking around contraindications. On one side, you have your absolute contraindications. These are your hard stops, your clear no-go scenarios. Things like a known esophageal perforation, a tumor, or an active upper GI bleed. In those cases, the risk is simply prohibitive, period. But then you have this much larger grayer area, the relative contraindications. This is where conditions like coagulopathy, thrombocytopenia, and large grade 3 esophageal varices live. And let's be honest, almost all of our liver transplant patients have some degree of these. So this isn't a simple no. This is where clinical judgment is paramount. It's a proceed with extreme caution, and it requires a thoughtful, individualized risk-benefit analysis for every single patient.
Now, the good news is we are not powerless here. We can actively and significantly mitigate that risk, and it all comes down to following a strict procedural protocol, like a safety checklist. First, and this is non-negotiable, the exam must be performed by an experienced, certified operator. Second, you have to know what you're dealing with before you start. That means getting a contemporaneous endoscopic assessment within the last 12 months is a good rule of thumb to know the size and status of the varices. Third, technique matters. Using a laryngoscope to assist with probe insertion can significantly reduce oropharyngeal trauma. Fourth, once the probe is in place, be gentle. Limit unnecessary manipulation, especially those wide flexion movements needed for transgastric views in high-risk patients. You can even place the probe in freeze mode when you're not actively acquiring images to limit any thermal or mechanical effects. And finally, be prepared for the worst-case scenario. Having an interventional gastroenterology team available for emergencies is just smart practice. Following these steps can make a world of difference.
All right, we've had a thorough discussion on safety. Now let's pivot back to utility and talk about the TEE diagnostic toolkit. Picture the scene. You're in the middle of a complex case and your patient's blood pressure suddenly tanks. The alarms are screaming, you need answers, and you need them now. This is the moment where TEE transforms from being just another monitor into your primary diagnostic weapon. It allows you to look past the ambiguous numbers on the screen and directly visualize the underlying problem. Now, a comprehensive 28-view TEE exam is fantastic, but let's be realistic. In a crisis, you simply don't have time for that. What you need is a focused, rapid, goal-directed protocol. And research has shown that with just these few core views, you can rapidly diagnose the vast majority of common causes of hypotension. The mid-esophageal four-chamber view gives you that quick global look at both ventricles. The ME-LV long-axis view is absolutely essential for spotting LVOTO. The bicaval view is perfect for a bubble study to rule out a PFO. The RV inflow-outflow is key for evaluating RV function. And my personal favorite, the transgastric mid-papillary short-axis view, that is your money shot for assessing LV preload and looking for signs of ischemia. It's all about being efficient and targeted when seconds count. This table right here, this is the key. This is the diagnostic flowchart that every transplant anesthesiologist should have etched in their mind. Because with TEE, we stop treating a number, the blood pressure, and we start treating the actual underlying pathology. So the patient is hypotensive. What does the TEE show? If you get a transgastric short-axis view and see a tiny, underfilled, hyperdynamic left ventricle with the papillary muscles practically touching, that's hypovolemia. The treatment is volume. But what if, instead, you look at the ME four-chamber view and see a massively dilated, poorly contracting right ventricle with the interventricular septum flattening and bowing into the LV, that classic D sign? That's acute RV failure. And giving that patient a huge fluid bolus could be disastrous. See the difference? TE gives you the specific diagnosis, which then dictates a specific and often completely different therapeutic path. Okay, let's up the ante now. In this next section, we're going to examine specific high acuity scenarios where TEE transcends its role as just a monitor and becomes a critical, life-saving interventional tool. These are the moments that truly define the value of having TEE in the operating room during a liver transplant. The first one we have to discuss is the most anticipated and feared crisis in any liver transplant, post-reperfusion syndrome. You've made it through the entire surgery, you're on the home stretch, the surgeon unclamps the portal vein, and all hell breaks loose. The mean arterial pressure plummets by more than 30% and stays there.
It's this sudden, multifactorial cardiovascular collapse triggered by the new graft releasing a toxic cocktail of cold, acidotic, hyperkalemic, and cytokine-rich effluent into the central circulation. It's a complex mess, and TEE is uniquely positioned to help us dissect and understand it in real time.
And here is the critical distinction. Hypotension is not a diagnosis, it's a symptom. During reperfusion syndrome, TEE allows us to pinpoint the specific cause. Is the right ventricle failing under the sudden surge of preload from the unclamped IVC? We'll see it dilate and develop severe tricuspid regurgitation. In that case, the treatment might be inotropes and pulmonary vasodilators. Or, did a thrombus get flushed from the graft and is now lodged in the pulmonary artery? TEE will spot it immediately, differentiating embolic shock from simple vasodilation, and the treatment is completely different. TEE can also show us if the ventricle is actually underfilled, suggesting massive volume sequestration into the new graft, or if the myocardium is simply stunned from all the inflammatory mediators. Instead of blindly treating hypotension, we can see the cause and tailor our therapy with precision.
Let's focus for a moment on one of the most feared of these complications, intracardiac thrombosis, or ICT. Its reported incidence can be as high as 6.2% in some series, which is terrifying. And as this quote highlights, its presentation is absolutely catastrophic. A sudden spike in pulmonary artery pressure, profound systemic hypotension, and very often rapid progression to cardiac arrest. Without direct visualization, the diagnosis is often one of exclusion, made far too late, if at all.
The difference that TEE makes in managing ICT is literally night and day. Without TEE, you are flying blind. You see refractory shock, you see the CBP and PAP rising, and you suspect a massive pulmonary embolism. Any treatment, like administering a high-risk drug like TPA, is a presumptive, high-stakes guess. But with TEE, the lights come on. The diagnosis is immediate and definitive. You see the thrombus, clear as day, tumbling in the right atrium or lodged in the pulmonary artery. You can confidently administer thrombolytics, and, this is the amazing part, you can watch in real time as the clot dissolves and right ventricular function begins to improve. TEE transforms management from a gamble to a visually guided, targeted therapy. And here's another critical intervention, where a conventional therapy is not just ineffective, but actively harmful. In dynamic left ventricular outflow tract obstruction, the patient is hypotensive, often in the context of hypovolemia, and a hyperdynamic state. Our standard reflex is to give more vasopressors and inotropes. But in LVOTO, that is the absolute worst thing you can do. It only worsens the obstruction, creating a death spiral of refractory shock. It's only with TEE that you can provide the correct diagnosis by visualizing the telltale sign, the systolic anterior motion, or SAM, of the mitral valve leaflet. And once you see that, you know to do the complete opposite of your instincts. Stop the inotropes, give volume cautiously, and use beta blockers to slow the heart down. The result is often an immediate and dramatic resolution. It's a true game changer. So, with TEE's value clearly established for managing intraoperative crises, let's look ahead. What's on the horizon? Advanced techniques are now allowing us to refine our understanding of cardiac function, moving beyond traditional and often insensitive metrics. This is where speckle tracking echocardiography, or STE, comes into the picture. For decades, the ejection fraction, or EF, has been our go-to measure of systolic function, but we all know its limitations. It's highly dependent on preload and afterload. And specifically in patients with cirrhosis, they often have this hyperdynamic, low afterload state that can artificially preserve their EF, masking significant underlying myocardial dysfunction, what we call cirrhotic cardiomyopathy. Global longitudinal strain, or GLS, which is derived from speckle tracking, offers a far more sensitive window into true myocardial health. It measures the deformation, the stretching and shortening of the myocardium itself. Because of this, it can unmask this subclinical dysfunction long before the EF even begins to fall. The advantages of incorporating GLS into our assessments are profound. It's not only more sensitive at detecting subclinical problems, it's also more reproducible than just eyeballing an ejection fraction. But here's the most important part. It provides prognostic information. Multiple studies have now shown that abnormal preoperative GLS values correlate with an increased incidence of postoperative cardiorespiratory complications. Think about what that means. It allows for earlier identification of patients who might benefit from preoperative optimization or specific intraoperative therapies. The key takeaway is that technologies like STE are pushing the boundaries, allowing us to move from a reactive management style to a proactive, data-driven approach to risk assessment. So, to summarize, the evidence and our clinical experience are simply overwhelming. TEE provides critical, actionable information that is unobtainable from any other monitor in our arsenal. It directly impacts our management, it transforms our ability to handle those rare but life-threatening conditions, and it ultimately improves patient safety. It has truly earned its place as the standard of care in modern liver transplant anesthesia. And we'll end with this final thought: the evolution of our monitoring, from relying on indirect numbers on a screen to having direct, real-time visualization of pathophysiology, is fundamentally changing our field. As tools like TEE and advanced techniques like GLS become more integrated into our daily practice, we have to ask, how will this deeper understanding reshape not just our intraoperative decisions, but how we define and prepare our highest-risk patients for surgery in the first place? Thank you for joining this explainer.